So today we are going to study the cardiomyopathies. There are three types of cardiomyopathies: dilated cardiomyopathy, hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. So starting with dilated cardiomyopathy, it is the most common type of cardiomyopathy affecting 90% of cases. It is often idiopathic, however, it can also occur in familial cases. That is, it is transferred from parents to offsprings. That is due to mutation of the TTN gene. The TTN gene is responsible for the synthesis of sarcomeric protein titin and the cardiomyopathy. The other factors that could cause dilated cardiomyopathy include drugs such as alcohol, cocaine, doxorubicin, infections such as Coxsackie virus, ischemic heart disease, a well-known risk factor, and other many systemic conditions such as hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi. Wet beriberi is due to the thiamine deficiency. Then we have the findings of dilated cardiomyopathy. So the findings of dilated cardiomyopathy include heart failure, S3 heart sound, it is an added heart sound. There might be systolic regurgitation murmur, and the CXR will show a characteristic appearance of dilated heart, that is the balloon-like appearance. The treatment of dilated cardiomyopathy includes sodium restriction since there is overfluid. There is increase in the amount of preload and the heart is not able to pump as much blood, so we need to restrict the preload. It is achieved through the sodium restriction and the loop diuretics and many other drugs such as ACE inhibitor or angiotensin receptor blockers have proven much beneficial in dilated cardiomyopathy. The other drugs include beta blockers, scubatril, and diuretics as already. Digoxin, ECD, and heart transplant can also be used in severe cases. So dilated cardiomyopathy leads to systolic dysfunction. Dilated cardiomyopathy displays an eccentric hypertrophy, contrasts with the concentric hypertrophy which is seen in the hypertrophic cardiomyopathy. Takotsu cardiomyopathy is a subtype of cardiomyopathy which is also known as broken heart syndrome. So it is basically due to ventricular apical ballooning, which is likely due to sympathetic overstimulation such as stress stimulation. So what happens is when there is the surge of sympathetic activity, this results in ventricular apical ballooning, and the ventricular apical ballooning results in eventual rupture of the heart tissue, resulting in broken heart syndrome, also known as cardiomyopathy. Next up, we have the hypertrophic cardiomyopathy. So, the 60 to 70% of cases of hypertrophic cardiomyopathy are familial disease. They are transferred in an autosomal dominant fashion from parents to their offsprings. It is most common due to mutations in genes that encode sarcomeric proteins such as myosin binding protein C and beta myosin heavy chain. It results in syncope that is most prominent during the exercise. However, in young athletes, it is also known to cause sudden death that is due to ventricular arrhythmias. The findings of hypertrophic cardiomyopathy in a patient include S4 heart sound, there will be systolic murmur. The vegetation may be seen due to impaired mitral valve closure. The treatment of hypertrophic cardiomyopathy doesn't involve many drugs. Most of the drugs that are used include beta blockers or protein channel blockers. However, ICD can also be used if there is cases of recurrent sympathy. We need to avoid drugs that decrease the preload, such as diuretics and vasodilators, because as the volume will be low, so there will be more blockage. Hypertrophic cardiomyopathy results in diastolic dysfunction. There is marked ventricular concentric hypertrophy, that is, the sarcomeres are located in parallel. There is often septal predominance. It is known as hypertrophic obstructive cardiomyopathy because the outflow from the left ventricle is obstructed due to contraction of the heart. The asymmetric septal hypertrophy and systolic anterior motion of the mitral valve results in outflow obstruction, and this may cause dyspnea and possible syncope. The other causes of concentric left ventricular hypertrophy include chronic hypertension and static ataxia. Then we have the infiltrative cardiomyopathy. This cardiomyopathy is basically due to infiltration of some exogenous material. It may be post-radiation fibrosis, it may be lobular endocarditis, that is eosinophilic endocarditis, or it may be due to endocardial fibroelastosis, that is thick fibroelastic tissue in the endocardium of young children. The other causes include amyloidosis, sarcoidosis, and hemochromatosis. It also results in diastolic dysfunction. It can have low voltage ECG despite thick myocardium, especially in amyloidosis. So low-flow endocarditis, as I told before, it's a hypereosinophilic syndrome. The histology shows eosinophilic infiltrates in the myocardium. Next, we have heart failure. So, what's heart failure is basically a clinical syndrome of cardiac pump dysfunction that may be due to obstructive, it may be hypertrophic, it may be dilated, or it may be infiltrative. So there is congestion and low perfusion. The symptoms include dyspnea, dyspnea that is the shortness of breath, orthopnea, orthopnea is basically the shortness of breath while lying down, and there is fatigue, and signs include S3 heart sound, jugular venous distension, and pitting edema. So the systolic dysfunction, there is a reduced ejection fraction, there is increase in diastolic volume, and these two are because there is less contractility, often due to ischemia or myocardial infarction or dilated cardiomyopathy. In diastolic dysfunction, there is preserved ejection fraction and there is normal end diastolic volume. That is because there is decreased compliance of the heart, often due to myocardial hypertrophy, but the hypertrophic myocardium is able to pump enough blood to conserve the ejection fraction and end diastolic volume. The right heart failure is most often caused by left heart failure. Right heart failure is also known as pulmonary when it is isolated and may be due to a pulmonary cause such as COPD. The ACE inhibitors or angiotensin receptor blockers, beta blockers, and spironolactone decreases the mortality. So these are life-saving drugs. The ACE inhibitors, the ERBs, the beta blockers, and the spironolactone. These are known as life-saving drugs in the heart failure. So loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine, which is an alpha blocker with nitrate therapy, which is a venous dilator, improves both symptoms and mortality in selected patients. So the left heart failure is when the heart cannot pump blood. Mainly the left ventricle is unable to pump blood into the body. The main causes of left heart failure we have already stated before. Heart cannot pump blood into the body, there will be backflow of blood into the lungs, and this will result in the two classical symptoms that are orthopnea and paroxysmal nocturnal dyspnea. So the orthopnea is shortness of breath when lying supine. Then we have paroxysmal nocturnal dyspnea, that is breathlessness that causes the person to awaken from his sleep. That is pulmonary edema, that is due to increased pulmonary venous pressure that results in pulmonary venous distension and transudation of fluid. Presence of hemocentral level macrophages or the heart failure cells in lungs indicates pulmonary edema. Then you have right heart failure. Right heart failure is a condition when the right heart cannot pump blood into the lungs for oxygenation. So there is lack of blood into the body. So there is no orthopnea or dyspnea in this condition. However, hepatomegaly due to increased venous congestion and jugular venous distension and peripheral edema are again signs of right heart failure.